Good afternoon, and welcome to today's Maternal Health Community Conversation, presented by Johns Hopkins Medicine, a proud local sponsor of the American Heart Association and Go Red for Women. I'm Tracy Brazelton, Executive Director of the American Heart Association of Baltimore and Greater Maryland. Cardiovascular disease is the leading cause of of maternal death in the United States, or more simply put, heart disease is the number one killer of new moms. It can pose a threat to women's heart health during pregnancy and later in life, making it important that women understand how to care for themselves and their baby. Go Red for Women is here to support women in all stages of life and all stages of pregnancy. And today, we are so fortunate to be joined by Dr. Stacy Fisher, the Associate Director of the Adult Congenital Heart Disease Center at the Johns Hopkins Heart and Vascular Institute in Baltimore, and an expert in pregnancy-related heart disease. If you have any questions throughout today's presentation, please share them in the chat, and we will do our best to address them. And now, I'm pleased to present Dr. Stacy Fisher.
Thank you so much for joining today, and it's really an honor to be here right around the time of the 100-year 100-year existence of the American Heart Association, who's so supportive and so wonderful as a partner. It's my favorite topic to discuss heart disease and pregnancy, and why it's my favorite topic is because with care, we expect to have good outcomes. So I wanted to go through some of the general information and issues related to pregnancy and heart disease. So there are a lot of different types of heart disease, which really is a bigger topic overall. We look at congenital heart disease, valvular disease, cardiomyopathies, and coronary disease really as different underlying conditions, different underlying management issues, and they have different implications. So we use sometimes the UK data, and the slides that look like this are based on UK data because they have very good population databasing. So we can tell that worldwide, cardiac disease is the leading killer of maternal death. Suicide, venous thromboembolism also are have significant impacts in pregnancy related issues. Today we're focusing on the cardiovascular issues. And diagnosis in pregnancy can be extremely difficult. It can be very hard to tell if somebody has normal changes and effects of pregnancy, or if they actually are struggling with heart disease in pregnancy. Things like shortness of breath, some swelling, rapid heart rate, they can actually be normal in pregnancy. So normal changes in pregnancy, things like shortness of breath, swelling of the legs, lightheadedness, even fainting early in pregnancy, don't have to be symptoms of heart disease, but they can be symptoms of heart disease. So it can be hard for you or for us to distinguish whether or not normal pregnancy changes are heart disease, or whether you're having difficulty with underlying heart disease. So sometimes we actually do need objective evaluation, things like the medical exam in person, the EKG or the echocardiogram. They can really give us a lot of information about whether or not you're okay and whether or not you're tolerating the normal changes of pregnancy, which are very significant. So normal changes include increased cardiac demands, increased blood volume. These are usually well tolerated, but problems can arise. So again, it's important to discuss these issues. If you're feeling something that you're not sure is okay or not, discuss it with your maternal fetal medicine doctor, with your OB, with your cardiologist if you have one. So in pregnancy, there's a marked increase in plasma volume, in cardiac output. Heart rate normally goes up. So a lot of people wear a heart rate watch, and they will notice that their heart rate goes up 10 to 20 points from their baseline during pregnancy. That is a normal expected change. What would not be normal is more than that, or lightheadedness, Again, if you feel faint, you want to address that right away and also discuss that with your doctor. Or if the heartbeat is irregular and associated with the lightheadedness, then we get a little bit more excited about that. So preconceptual counseling is critical. The importance I cannot understate. Having prenatal care is very important. Having preconceptual care is equally important. So if you're taking chances, you're stopping birth control, you are thinking about your own health and your fertility, talk to your doctors about it. Ask the question of what is my risk and can I do anything to optimize my health before I move on with the pregnancy? And that can alleviate and prevent many of the things that do come up in pregnancy. Most women who have underlying heart disease do consider pregnancy. Most women with underlying heart disease can have a successful, healthy pregnancy. So assessing the risks and optimizing health before pregnancy is critical. Part of that is reviewing the medications, the structure, functional capacity. This may include blood pressure, looking at family history, your electrocardiogram, and sometimes an echocardiogram, which is an ultrasound of your own heart. Evaluation by a maternal fetal medicine specialist is really important if you have underlying heart disease. Your OB will help you decide whether or not you need this specialty care during pregnancy. Management plan for pregnancy monitoring, labor and delivery monitoring, and a labor plan in people that have heart disease and decide to undergo pregnancy is incredibly important and helpful and will help guide your physicians so that mistakes are avoided. Genetics are also part of what we need to think about and do. So women with congenital heart disease are more likely to have children with congenital heart disease. This can be as much as 5 to 10% versus less than 1% of the general population. Note that the child's defect may be the same, but can be different than the mother's. Genetic testing can also be done. Often it's a saliva test. Genetic counseling is very important through pregnancy, trying to understand your own genetics and also how to have the healthiest family and lineage that you can give. Discussion of contraceptive options and family planning can also be part of your preconceptual counseling, especially if you're having this counseling when you're not actually ready to move forward with a pregnancy. Importantly is a comprehensive care team. This is probably the most important thing that we're going to talk about today. If you have something like underlying congenital heart disease, you're born with a structural problem that needs management and supervision, that needs higher level care. You want to have a team and you want to understand what all parts of that team can do and who to call for evaluation or screening. The team should include your cardiologist, your maternal fetal medicine doctor, discussion of genetics, imaging. You should be up to date on your imaging and understand that you've optimized any anatomical issues that may come up that may be a barrier to dealing with all of the changes in volume and heart rate and need that the body has to actually augment the cardiac function during pregnancy. You want to review your medications and make sure you're not on anything that's unsafe for you or your child during the pregnancy. And change over to medications that are safer in pregnancy if you need to. And you want to do that before you start the pregnancy. Heart rhythm management is really important. Many of our patients have difficulty with heart rhythm issues. And again, with the added stress of pregnancy and the faster heart rate that occurs with pregnancy, this is a time where underlying heart rhythm issues can be unroofed by the challenges that the pregnancy brings. Sometimes, and more rarely we hope, there's a need for things like cardiac surgery, intervention, or anesthesia care. And those members need to be part of the overall care team so that they're prepared for anything that could arise and they already understand your underlying structure. Things that are true contraindications to pregnancy, where the risk of pregnancy really is very high and the outcomes are not as good as are considered acceptable. These are severe pulmonary hypertension, reduced heart muscle function, obstructed blood flow, low oxygen levels such as cyanotic heart conditions, severely dilated aorta, and relative high risk also includes mechanical heart valves. I would be remiss if I didn't go over the most common issue during pregnancy, even in those that have never had an issue, and that's hypertension. So hypertension with a general diagnosis at 140/90 on several consecutive measurements. People in pregnancy, 1 to 5% of pregnancies may have pre-existing hypertension. This also is counted as pre-existing hypertension if the high blood pressure measurement happens before 20 weeks of gestation. This is generally something that's pre-existing that can be exacerbated in pregnancy, and it generally does persist postpartum. Patients can have protein in the urine or can have complications of the pregnancy. So management and monitoring is very, very important if you have hypertension going into the pregnancy. Gestational hypertension, the definition is that it's new after 20 weeks of gestation. This often resolves within 42 days after delivery. So many times medications and monitoring are short-term. We have to watch for organ perfusion, meaning your organs and the child's organs related to changes in blood flow related to the high blood pressure. Sometimes high blood pressure is actually a symptom of decreased organ perfusion to the fetus. So we always look at fetal issues and fetal health, making a decision about gestational hypertension. Pre-existing hypertension can also be superimposed with gestational hypertension, and one of the best ways to look for that is protein in the urine. So you may be asked for a 24-hour urine and also spot urine samples to double check for protein. Antenatally unclassifiable means that somebody hasn't had regular medical care, hasn't had a blood pressure check, doesn't know what their blood pressure was going into the pregnancy. I'm hopeful that everybody on this Zoom call or watching this video will actually just check their blood pressure and know what their blood pressure is, so that you know if it's new or old, you know if you're having difficulty, and having a baseline is incredibly important for that. That's also why preconceptual and prenatal care is so important, so that you can pre-treat problems before they become emergencies. And that changes the outcomes tremendously. So assessments and monitoring during pregnancy include blood pressure, blood work, urinalysis sometimes, and if you do have high blood pressure, we often look at uric acid levels too, which is another blood test. So in high blood pressure management and monitoring during pregnancy, people who have pre-existing hypertension have high risk of superimposed pregnancy-related hypertension like preeclampsia, and they need special monitoring, extra treatment. Often blood pressure cuffs are actually covered by insurance during pregnancy, and home monitoring is really, really important. Low-dose aspirin has been shown to actually help prevent preeclampsia. It's now generally recommended for anybody 35 or older during pregnancy, anybody who's had hypertension, and certain underlying heart conditions. And this is usually initiated at week 12 and is stopped around weeks 36 to 37, so that you don't have the aspirin necessarily in your body at delivery, which can increase bleeding. In women who have mild preeclampsia or gestational hypertension, delivery is recommended only after 37 weeks. It's also recommended to expedite delivery in preeclampsia if there's an adverse condition like visual disturbances or hemostatic disorders. There are some really good registries and trials of pregnancy and heart disease. One of them is called ROPAC, and that actually looks at all patients who have had pregnancy and heart disease. And importantly, it really helped identify some of the contraindications to pregnancy that I reported to you earlier, which is people who have pulmonary arterial hypertension or weaker heart muscles or mechanical heart valves. Importantly, adverse outcomes were much, much higher in people that had poor functional capacity, meaning that you have symptoms of heart disease when you're not doing very much, either sitting and resting or just trying to walk across the room or just doing your very light duties of daily life. If you have symptoms of heart disease before pregnancy with those levels, the risk of pregnancy is going to be very, very high because the extra work that you have to do to deal with the extra blood volume, the developing the baby's support, the higher heart rate, the surgical aspects of labor and delivery are high, and you need the reserve to tolerate that. So very, very important. Also important in registries and in data that have really come to light over the past few years is that people who have artificial heart valves do have more adverse pregnancy events than we suspected. So there are surprising rates of maternal and fetal poor outcomes in patients with all types of heart valves, especially if they're not functioning normally. So the rates in people who have normally functioning bioprosthetic valves are much better than if they have abnormally functioning bioprosthetic valves, but they're still higher than we would like to see. And mechanical heart valves have higher rates than the bioprosthetic heart valves. So congenital heart disease, meaning disease that somebody was born with that has been palliated through childhood, that they are living with, that has become part of who they are. It's very important that they actually talk to their providers and understand individual risks and challenges that may come with pregnancy. Most of the women with congenital heart disease can have a successful pregnancy, but the care needs to be different and the attention to their health needs to be different during pregnancy. And because this is not the case with everyone, it's really important for adult women with congenital heart disease to know their individual risks and to actually be very upfront and very clear about their desires and their willingness to take risks if they want to enter into the condition of pregnancy. So the key question really needs to be answered, is what is the risk to the mother and what is the risk to the fetus in this exact individual? There are studies, there is a Zahara study, 1 and 2, that looks at predictors of maternal cardiovascular events and again found that same risk of high-risk patients. Also, certain blood markers like natriuretic peptide levels, smoking history, which is modifiable, right? You can stop smoking. Whether or not you have a mechanical valve prosthesis is not modifiable necessarily during pregnancy. And again, whether you have had repair to the best of the ability of anything that lowers your oxygen level. So this is the type of thing that has come out of looking at these larger populations and understanding who has had events and what contributed to those events so that we can address those before they become a problem in you. So ideal management would be pre-pregnancy counseling, multidisciplinary involvement, your high-risk OB, anesthesia, neonatology, and genetic support, fetal echo screening for congenital heart disease in the child, and close surveillance, including blood pressure monitoring at home. For diagnosis, we often use your family history, your EKG, which is the electrical monitoring of the heart, sometimes actually monitors that you wear for a little bit longer that can show us what type of rhythms you're having over a longer period of time. The wearable technologies are also very, very helpful and may be very helpful through the pregnancy to understand if you're starting to see different rhythm issues during the pregnancy. Echocardiography is ultrasound of your heart and can show us the structure, function, and pressures within the heart. Also for aortic disease, we can see the size and shape of the vessels. MRI can be done, but only without the dye, without gadolinium during pregnancy. The structure can be seen, some of the blood flows or percentages of blood flows are not available without the dye. So we are a little bit limited in our imaging during pregnancy. Exercise testing before pregnancy can really help you understand what the reserve is and whether or not you're going to tolerate a pregnancy and the stresses that it brings. During pregnancy, if there's a reason that we need an exercise test, we usually go to 80% of the predicted maximal heart rate. And with exercise in general, we recommend that you exercise to about 60–65% of the predicted heart rate for your age. Radiation exposure is something that we've always been told to stay away from. We don't want to do. However, current technologies are low dose radiation. So if you are having difficulty where you need a cardiac test and it may have findings that could save your life, do not hesitate to have the radiation procedures done. There is absolutely no evidence of increased fetal risk for doses less than 50 milligray. And if you look, for example, at an X-ray, for the mom, the exposure is 0.1 milligray, and for the fetus, it's less than 0.01. So these are very, very low exposure rates. If you needed a catheter intervention, you're still well below those numbers. Now, we don't routinely offer these procedures unless you need them. The main exceptions where we highly recommend them is looking for blood clot if you're having chest pain and have a D-dimer elevation. That's a blood test that can support the possibility of clotting. And again, the issue is that you need a good diagnosis. You need to know if it's there or not. If you have a blood clot, you're going to be on blood thinners through pregnancy. Those have their own risk. So you only want to be on them if you need them. And if you need them, they're life-saving. So you really do want to have the test to figure out if you need to go down that pathway. So again, we would not hesitate at all at any stage of pregnancy to do a CT scan to rule out a suspicion of pulmonary embolism. Also, if you're having a heart attack, we would certainly want to save your life. And again, the risk is actually small. The theoretical risk is bigger than the actual risk. So that's why I wanted to share these numbers. Aortic disease in pregnancy is also very, very important. Things like aneurysm or dissection are less common, but extremely important because the state of pregnancy can contribute to further dilation of the aorta. Sometimes we actually find that dilation of the aorta occurs more during breastfeeding than actually during the pregnancy. So continued surveillance after pregnancy is also important. If somebody has known aortic disease or a condition where they're more likely to have aortic disease, like a bicuspid aortic valve or Marfan syndrome, Loeys-Dietz syndrome, a full assessment and counseling should be performed before the pregnancy. People that have a type B dissection, which is the middle of the chest or past the arch, have had successful pregnancies, but we always advise against pregnancy because there is a risk that it can extend the tearing of the aorta, and that can be catastrophic. In patients who have a type B dissection or genetic predisposition, we also recommend that if they choose to go ahead with a pregnancy, we follow extremely strict blood pressure control and monitoring guidelines. Prophylactic surgery should be considered hopefully before pregnancy, during pregnancy if it's worsening in pregnancy, if the aortic diameter is increasing or meets certain guidelines, which again, this number can vary depending on the conditions that are associated. In somebody who has an increasing aortic dimension, delivery should happen as soon as the fetus is viable. It should be a cesarean or a second stage assisted delivery, followed by aortic surgery in the mom. Patients who have undergone previous successful surgical repair often tolerate pregnancy really well, and the people who are low risk should know they're low risk. No mechanical valve, good exercise tolerance, normal heart muscle function. If you're low risk, have that conversation, know that you're low risk, and have normal active discussions about what's best for you in your life and pregnancy planning. So timing and mode of delivery, you want to favor spontaneous onset of labor and vaginal delivery in most cases. Wide use of lumbar epidural analgesia, because taking pain away can decrease the cardiac work. Indications for cesarean section may really differ between institutions, where some institutions actually have a lot of experience with second stage passive delivery with vacuum or forceps delivery, and some institutions really don't use them very often, in which case the risk of using them is higher. So in patients who have preterm labor and they're on a blood thinner, cesarean section is certainly indicated because the baby is also anticoagulated and delivery can cause bleeds for the baby. So again, part of our recommendations are taking into account of the mom, and part are taking into account of the child, and we're always putting those together and trying to give a woman the best opportunity for both good outcomes. So these are really important considerations that you should be discussing all the way through, so that there are no surprises as you get toward labor and delivery. And that is the beauty of having multidisciplinary care and putting together a group ahead of time. Coronary disease has always been rare in pregnancy, but because women are choosing to get pregnant older and have more underlying comorbidities and are not finding those as much of a barrier to pregnancy, we're seeing more issues with coronary events. So coronary events can be due to atherosclerosis, but also due to clotting issues or tearing of the vessels. These should be managed invasively with imaging. Often we can actually use medications to stabilize the problem until after delivery or even long term. Sometimes it actually heals unless you actually have a clot or a plaque that is blocking blood flow to the heart. In which case you really need to do a coronary intervention in the heart cath lab. Pregnancy can be considered in women who have had prior heart events, coronary events, if there's no residual ischemia on their testing and their ejection fraction, or how much blood gets out of the heart on each beat, is greater than 40%. Normal would be 55 to 65%. An unusual condition called spontaneous coronary artery dissection is often seen primarily in pregnancy, and the incidence is increasing in pregnant women, again because of underlying comorbidities during pregnancy in the current population of pregnant patients. A tear or dissection can affect the left main or the left anterior descending artery. It can be secondary to the hormonal changes of pregnancy, and also to the stress that the body undergoes from the hemodynamic changes we talked about. They can cause arterial wall weakening. More likely with underlying connective tissue disease such as fibromuscular dysplasia or lupus, this can occur. Diagnosis can be made using coronary angiography, and the management is generally medications, but can actually need interventional care. Arrhythmias are unusual in pregnancy, are more usual in those that have had them before pregnancy or in congenital or structural heart patients. And then those patients can develop in up to 15% of the patients during pregnancy. If somebody is unstable, we always look at cardioversion, which is a shock back to normal. Arrhythmias from atrial flutter or atrial fibrillation, those specific arrhythmias, are rare, but we always prefer cardioversion, and blood thinners are very important in pregnancy because pregnancy we consider a clotting state. The risks of clotting are higher. Life-threatening ventricular arrhythmias during pregnancy are really exceedingly rare. Medication and treatment considerations, we look at every medication during pregnancy for safety. We also look at what's really required for heart management and for safety of the underlying heart disease. In an emergency, we would use the same medicines that we would use whether somebody is pregnant or not, always with a risk-benefit review. We look at FDA category of the drug for its safety for the fetus. We look at whether or not it transfers in the placenta, whether it transfers through to the breast milk, and what are any potential adverse effects to the mother or to the fetus, and what are the benefits. And we always look at alternative treatment options. There are guidelines that are very helpful, and this is one of them that I recommend if you're interested more in looking at cardiovascular disease during pregnancy and sort of the state-of-the-art management. Support networks for women are developing with heart disease during pregnancy. There are online resources, support groups, and advocacy organizations, and I encourage you to use those. There's an importance of emotional support and mental health care that is underused and under-available during pregnancy. So talk to your providers, especially if you're feeling overwhelmed at all about pregnancy and heart disease. And I thank you very much. It's been an honor to be with you, and I'm certainly available to answer any questions.
Dr. Fisher, we do have some questions that have come in, and this viewer says, I have feelings that concern me during pregnancy, like shortness of breath or heart palpitations. How do I know if they are normal or abnormal in my pregnancy?
Well, that's a great question. So the first thing is really ask your doctor. So go to the doctor. You should have a doctor that you're working with during pregnancy, and ask your doctor. It can be impossible for you and sometimes even for your doctor to know. Now, if you're really having trouble, there will be certain findings on your exam that the doctor will pick up on that you may or may not be able to pick up on just from their training, and also because it's an objective person looking at you that can tell you if you need to do things faster. But sometimes we actually need to do an echocardiogram or an ultrasound of the heart to know if you're actually okay. There's a lot of discussion because the risk in pregnancy is actually higher with obesity as well. And the exam is more difficult in an obese patient during pregnancy because fluid can be hidden. It can be harder to hear. It can be harder to see actually the neck veins or the structures in the neck. So some of our regular assessments are more difficult or not as accurate or not even as good from provider to provider. So, so we can't rely on those. So we recommend earlier using echocardiography as an objective way to look at, is the heart okay? Are you actually getting enough filling? Is the function of the heart okay? Or are you developing a heart muscle problem like a peripartum cardiomyopathy or heart muscle problem related to the pregnancy?
So we have another question. Should I be as active as I normally am, more active, less active during the pregnancy to protect the baby?
That's actually really important. So we definitely recommend keeping exercise during pregnancy. And actually that exercise is very important for you and for the child. And also to prepare you for labor and delivery so that you have the stamina to go through labor and delivery. So we recommend that you absolutely do continue to exercise through pregnancy. Always a warm up and a cool down would go to about 65% of your peak exercise capacity, and continue aerobic exercise specifically, which is very important. Now, if you have limitations, you want to go to about 60–65% of those limitations rather than the full amount, because you already are doing about 40% more every time you're doing anything, just because you're supporting the pregnancy and the extra blood volume of the pregnancy.
Can you speak to cardiovascular implications of preeclampsia or gestational hypertension?
Absolutely. These are probably two of the most important topics that we could have when we're talking about trying to reduce maternal mortality. So gestational hypertension means that high blood pressure has developed after 20 weeks of gestation that did not exist before the pregnancy, or that is accelerated by the pregnancy above what would be expected. Gestational hypertension can be a remarkable risk factor for preeclampsia. So if someone has gestational hypertension, their risk of preeclampsia is much higher. Preeclampsia means that not only do you have hypertension, but you also have hypoperfusion. And the risk is actually very high of adverse events to both the mother and the fetus, where true preeclampsia is a reason for delivery. So if you can manage the hypertension, bring it down, keep the protein levels down that you're spilling from the kidneys, and have the blood pressure managed with medications that are safe for both the mother and the fetus, then it's okay to continue the pregnancy. If the blood pressure is not responsive, the protein levels are going up, you're getting any neurologic side effects, you really do have to deliver the mother to save the mother's life at that point. So preeclampsia is a much higher state of risk, and can be actually because of fetal stress. So if the fetus is in distress or the blood flow to the fetus is not strong enough, that can actually trigger preeclampsia to show up in the mom as a sign of fetal distress. So it can be the perfusion to the baby that is what is actually causing the preeclampsia. So I'm not sure if that answers the question, but
There's actually a follow-up question, I believe. Can you speak to the atypical onset preeclampsia and causes if there was no existing hypertension prior to pregnancy?
so causes could be issues with fetal blood flow. It can be diastolic dysfunction or stiffness of the heart of the mom where they're actually retaining a lot more fluid. It can be related to the vascular disease in the mom that can limit the blood flow. So it's usually vascular endothelial function in the mom's system. And that's why, again, optimizing the health of the mom before pregnancy can make all the difference in avoiding or delaying the onset of preeclampsia. And if you've had preeclampsia, again, we also do recommend starting aspirin, or if you have high risk of preeclampsia. Older age is also a risk factor for preeclampsia.
Here's a related question. Do heart-related pregnancy outcomes differ based on age or race?
Yes, so they actually do. Having heart disease in pregnancy would be more common in somebody that has advanced maternal age, which is 35 or older. And as you increase age, it's much more common. And there are definitely a lot of disparities in care that lead to maternal adverse outcomes related to access to care, belief in care, willingness to participate in care, and trust in care. So always we want you to have preconceptual counseling, find a care team that you're comfortable with. Make sure that you have open, honest discussions about your own thoughts about your care and what you want for your care, and also honest discussions about your own risk tolerance for pregnancy if you have heart disease underlying. So that's actually really, really important. I wanted to add one thing to the preeclampsia question that was asked earlier, which is people who have had preeclampsia are at higher risk later, or even gestational hypertension, but especially preeclampsia. There's higher risk of coronary and stroke adverse outcomes later. So even after pregnancy and delivery, you want to actually stay in preventive cardiac care where you know your numbers, you're addressing your cholesterol, your blood pressure, your weight, your exercise level, where you are truly trying to optimize your cardiovascular health so that you avoid those adverse outcomes.
Any clinical guidance on postpartum follow-up for patients with a new diagnosis of hypertension? And how can hospitals help to facilitate and encourage care?
So if somebody has a new diagnosis of hypertension, first of all, the most important thing they could do, number one, is get a cuff. A lot of insurances do cover cuffs. Some of the hospitals will provide cuffs, which is something that they could do. But having a cuff that properly fits you would be very important so you know your numbers. It's also very important to lower salt in the diet. The best diet for lowering blood pressure is called the DASH diet, DASH, and you can Google that or look at that. But just a lower salt diet. So that's actually very, very important. Follow-up should include following the home blood pressures minimum weekly, but depending how bad it was, sometimes daily, until they normalize, and deciding, as it normalizes, if it normalizes, when it's the right time to come off of medications. Generally, for pregnancy-induced hypertension, the blood pressure normalizes by about 1 to 3 months after delivery. And usually you can actually come completely off of the medications, but you should regularly check the blood pressure, and it is certainly risky to develop hypertension over time, so you want to keep your health optimized to avoid that. What the hospital can do is to make sure that you have follow-up dates scheduled before you leave the hospital so that you actually have the appointment set. And also so that you have a communication pathway that you're comfortable with between you and your providers. So if you're getting abnormal numbers, you know how to call and ask for help. What you can do is to actually follow the diet, do the exercise, get up and get moving. Don't just go down, don't just go home and lay in bed. And really report things like increased swelling, increased numbers, use those communication methods, and go to the appointments. Don't reschedule or skip the appointments. You need to go get them done.
So another question, this listener says, I get a lot of leg swelling. Is that something I should address with my doctor, or is that something everybody gets?
So that's the exact right question. And everybody can get a little bit of leg swelling. It can absolutely be normal in pregnancy. A little bit, not a lot. Generally, that's worse when your legs are dependent, when they're dangling for a while, but after they're up, especially if they're up in bed overnight, it should be gone in the morning. If it's always there and it doesn't go away overnight, you definitely want to get in quickly. You also want to make sure that you are not having high blood pressure related to that. So if you have leg swelling and high blood pressure, that becomes even more concerning. Or for example, if you're more out of breath than you would expect and your legs are swollen, that's more concerning. You should absolutely discuss it with your doctor so that they can look at your legs, see if you have some venous insufficiency. Support socks during pregnancy in that case are really protective so that you don't get worsening varicose veins during pregnancy, and it will remarkably help aching or swelling in the lower legs.
How can I be my best advocate to my doctor? I don't have a history of hypertension, but I do have a family history and a cultural predisposition. I had slight high blood pressure at my 16-week appointment, but at home it has been normal or slightly high. How often should I be measuring at home to have accurate testing?
So I would check every day in that case during pregnancy and make a log. And normal average time, you're really trying to treat and look at your average blood pressure. So not when you've just run up the steps carrying laundry, or you have had an exciting phone call, or you've just exercised. You want to do it either when you first wake up or before bed. And write down time, date, pressure. Try to vary the times a little bit in case you're spiking at a certain time. That can make a big difference. And then bring the log with you for discussion. So you can just look down at all the numbers and it becomes very clear if it's really okay or not. People who have truly high blood pressure, it's almost always high. Some normal fluctuations are very important that you do have. Because you actually want to see that you can respond to different challenges.
That's great advice. Thank you. So this listener is asking regarding this discussion of swelling. Are there diagnostic implications of bilateral versus unilateral swelling during pregnancy? Are both normal?
So bilateral swelling is more normal than unilateral swelling. We worry about blood clots during pregnancy because pregnancy is a clotting state. So if you really have unilateral swelling without a reason for that, like an old injury, if you've had a knee replacement on that side might swell more. But if you have unilateral swelling that's new, you really do want to get a Doppler ultrasound, and we want to make sure that there's no blood clots. So that is very important.
One more question that has already come in. My family has an abnormal gene for heart muscle disease. How does that affect me and my pregnancy?
So that's actually really important. And we were starting to talk about the importance of genetics. So there can be genes that actually predispose people to heart muscle problems. And some of those genes can be turned on during the pressures and triggers of pregnancy. So if there's a gene that runs in your family, the pre-conceptual counseling would be a really good time to discuss that and to actually get tested for it and to know that particular gene's general pathway. Does it turn on in pregnancy? Is it something that could affect the fetus? Also, there is a lot of there are fertility options where if you have a particularly bad gene, say you have a Marfan's gene or a Titin gene, you can actually have screening of your eggs and then have fertility to only give you back the eggs that don't have that gene. So they can actually screen out the gene that has been traumatizing your family and that you have that puts your own health at risk. You can actually protect your child from having that gene, and then your children's children and their children's children. So your whole lineage becomes healthier. So there are a lot of options now. If you know your genetics and you know you have a cardiac gene that can cause problems for you and shorten your life, you can prevent your child from having that same issue. And you can also have better care during pregnancy with the higher risk multidisciplinary group.
I think that's all we have time for today. Dr. Fisher, I want to thank you on behalf of the American Heart Association and our very engaged listening audience for this excellent discussion. This is such an important topic, and we really appreciate having you here with us today, but more importantly, having you as one of the caregivers in our community who are helping people navigate this important topic as they begin to think about family planning and how that impacts their cardiovascular health. So thank you very much. Thank you to Johns Hopkins Medicine for making today's conversation possible. And again, thank you to our listening audience for your excellent questions.